Okay, the recording has begun and it will be on the committee's webpage shortly after the meeting. So I will ask Pam McEwen, the FTAC liaison to the Universal Healthcare Commission, to call the meeting to order.
Thank you, Mary. It's just 1 minute past 2 o'clock, and I'm happy to welcome all our FTAC members. We're going to begin with a land acknowledgement today. Although I'm in Seattle, I want to acknowledge much of our work resides in Olympia, the ancestral home of the Nisqually tribe. The Nisqually people have always been a fishing people and have lived in the Nisqually River watershed for thousands of years. Prior to the Medicine Creek Treaty, their homeland included about 2 million acres near present-day Olympia, Tenino, and DuPont, extending all the way to Mount Rainier in the east. Their current reservation is approximately 5,000 acres that stretches from northern Thurston County up through Joint Base Lewis McChord in Pierce County. I'd like to give a warm welcome to everyone who's joining us today. This is our 11th meeting. It's hard to believe. I'd also like to introduce 3 new staff members to the Healthcare Authority who are going to be supporting our work, and I am really excited about this. Mary Franson is going to be very capably filling the shoes of Angela Castro as the Coverage Strategies Manager. And then we're also welcoming Todd Bratton and Allie Power, who are Health Policy Analysis. This is some additional firepower that we've all been looking forward to. So thanks very much for joining the team. I'm going to start now with an overview of our agenda. We'll begin as always with our roll call, and we always like to use this as an opportunity for members of the committee to get to know each other a little better. So when your name is called, be ready to talk about what you're looking forward to on the first day of autumn. And then after the roll call, we're going to vote on the July meeting summary. And then, as always, that will be followed by public comments. After that, I'm going to take a few minutes to clarify some FTAC meeting procedures, just so that we have some clarity amongst ourselves and with the people who are following our work about actual actions that have been taken. And then next, HMA will share where we are in the Commission's 2024 work plan. Following this update, we're going to turn to the topic of costs and cost sharing. First, we will discuss an analysis that's going to be performed by Milliman, and then we're going to move into a discussion of cost sharing. Now, this is not just for the purposes of discussion, but this is actually to start to develop a set of principles that we can share with the Universal Healthcare Commission, as they had asked for a variety of cost sharing options, and this would accompany that work so that they can, if they accept it, to kind of give us a way to think about cost sharing. We'll take a short break, and when we return, the discussion will continue about additional areas of focus so that we can be clear about where we are directing our work next. As always, I encourage FTAC members to ask lots of questions and provide feedback to help facilitate today's discussion. I'm going to turn it back to Mary Franson now for our roll call.
Thank you, Pam. I'm going to call people alphabetical by first name. And as Pam mentioned, our icebreaker today is talking about the upcoming season of autumn. The days are going to get shorter and they're going to get colder. So tell us what you're looking forward to about that. So we'll start with Pam.
Okay, so I was well aware of the question beforehand, but I like pumpkin spice lattes and autumn leaves and all that as much as anybody. But this year, I'm very much looking forward to the fires being put out.
Yeah. And Christine. Yeah, Christine did let us know she is traveling right now, and I think she may be in traffic somewhere and is hoping to join us a little later. So, Christine, David.
Hello, I'm here, and I look forward to the cooler weather. Usually, when I get my fall coat out, I find $5 in the pocket, so I'm hoping to recreate that experience.
Eddie.
Present. I don't give it too much thought, but definitely the leaves changing and looking out towards fall is it's kind of a good time to pause and get away from the hot weather a bit.
Esther. Esther. Okay, Ian. I think I heard also from Ian that he was not able to join us. Kai?
Hey everyone, I'm looking forward to the fall harvest, in particular to the nice variety of apples that we get here in Washington State.
Robert?
Hi, everyone. I'm also looking forward to the harvest, but I live in the wine country, so they'll be harvesting grapes, and I notice when I'm driving by wineries, there's a little different smell in the air of crushed grapes. So nice to be here.
Thank you. And Roger?
Good afternoon. I'm looking forward to, I guess, embracing fall and winter in the context of taking a trip to the Whole River Valley to do some hiking.
Nice.
Sounds good.
Wet hiking, of course.
All right. Thank you, everyone. And Pam, I'll turn it back to you.
Thanks, Mary. So we're going to go to the second tab of your meeting packet. And the recording of the last meeting is also posted on our webpage. And we use a consensus process for voting on it. Before I ask for discussion, I want to note that we made one correction, which is that Bob Murray was indeed at the last meeting, and my apologies for that he was left off the meeting summary. And I'm going to propose that the minutes are accepted without other changes unless there's any discussion or any thoughts. Okay, doesn't sound like it. All in favor, say aye.
Aye.
Hi.
Anyone opposed? We are approved by consensus. Next, we're going to move to public comment. Committee members can find written public comments under tab 3, and we will allow individuals to sign up to provide public comment before the meeting, and we will start with those that have signed up to provide comments. When your name is called, please state your name and affiliation. And we will be displaying a timer as a reminder of the 90-second time limit. When the timer stops, please stop your public comments. Mary, you ready to start with the names and individuals who have signed up to provide comments?
Sure. Thank you, Pam. We had 3 people sign up ahead of time, and we will invite them to speak in the order in which they signed up. And the first person will be Andre Stackhouse.
There we are. Well, good afternoon, everyone, and thank you for having me for public comment today. And 90 seconds isn't a lot of time, so I just want to say thank you to this commission for running the analysis report on 5335. I've spent a bit more time with it now, and so I just want to say I think that this dialogue is incredibly important, and that we continue to substantively engage with it. So I have submitted as written comment, and it's available at wholewashington.org/commission, a detailed response that I hope can summarize some of Whole Washington's thoughts on the report. It's a draft right now. I'll be submitting a finalized one as it is ready. But it includes in it the entire fiscal note run on the original version of the Washington Health Trust 5222. I think there could be some very useful information in there. I also want to emphasize that the report identifies some incredibly key points of alignment between Whole Washington and this committee. And I think we really need to build off of those, including paths forward that tend to begin with state plans, PEB, SEB, and Medicaid. And these really need to be delivered to the legislature in the form of clear recommendations. So I hope that the November report will include a more detailed summary of this analysis report, as well as the entirety of the report as an appendix. Thank you.
Thank you, Andre. The next person we have is Catherine Lewandowski. And Catherine, you may be showing up as Whole Washington. I'm not sure.
Can you hear me?
Yes.
Oh, okay. I'm sorry. Yeah, yes, I am. So, yeah. Hello, my name is Catherine Lewandowski. I'm a retired registered nurse, and I'm the vice chair of Whole Washington. Oh, sorry. We're in this panelist. retired registered nurse and vice chair of Whole Washington. And regarding your topic of discussion today, adding cost sharing to a universal healthcare plan, I personally would highly encourage the committee to not recommend any additional cost sharing at the point of care. Although there have been many studies done that show how cost sharing does deter beneficiaries from seeking care until the symptoms become severe, I don't believe that there are adequate studies available that show that adding cost sharing improves outcomes. And since just about every study out there does show that we pay less with a single payer universal healthcare plan, like option A, could we just maybe keep those copays in our back pocket for now? Maybe it's possible for us to cover everyone with a cost-effective system and still save money. We know that initially there's going to be a rush on services, but what has been shown in other countries is that rush usually settles down after about a year, because the reality is we have a lot of people out there with unmet medical needs. Maybe after the dust settles and we find that we can afford to cover everyone without cost sharing, maybe after that we look at overall health outcomes and decide what is more important to our friends, family, neighbors, and communities. Putting disincentives for them to receive early care and possibly missing an early diagnosis. What value do we really place on the lives of the people we love? Thank you.
Thank you. Our next speaker will be Marcia Stedman.
Thank you very much. I'm pleased to join you today and I appreciate the opportunity. I am Marcia Stedman and I volunteer with Healthcare for All Washington as a member of their board of directors. As you consider cost sharing today, I'd like to draw your attention to the actuarial work done for the Universal Healthcare Work Group in 2021 that preceded the current commission. The presence or absence of cost sharing had a significant impact on the overall costs of they modeled. Two of the potential plans they modeled had no cost sharing and were projected to provide healthcare savings statewide, even in the first year of implementation. $2.5 billion for the publicly administered plan called Model A, $800 million for the insurance plan administered variant called Model B, while at the same time providing healthcare to all of our state residents. So their projections for a system with premium subsidies and cost sharing, dubbed Model C, would actually cost more to the state. It would cost $617 million more in the first year than our current system because of its commercial plan levels of administrative cost, which does include cost sharing. Now, 4 years have passed since that work group study, and we do need updated figures. I only call your attention to that previous study because their rubric included the presence of or absence of cost sharing for each plan modeled, which had a significant impact on the total overall cost of each plan. It's also important to note that the work group study was based on projected healthcare utilization in our own state of Washington and is more recent than other state studies you have heard about recently. So we urge you to include cost sharing in the rubric for Milliman's modeling. Would a plan with no cost sharing still offer the most savings while providing healthcare to all state residents? We need to know. Thank you.
Thank you. As we've been speaking, as folks have been speaking, some hands have gone up. I believe our next speaker is John Godfrey.
Thank you, committee members. My name is John Godfrey. I'm program manager for Washington CAN, a small business owner in Seattle. I also represent the coalition Healthcare is a Human Right. My comment today on cost sharing echoes some of the concerns that other members of the public have had, and including Catherine today. As a tool to rein in healthcare prices, cost sharing is a blunt instrument such that what benefits may be gained in terms of reducing utilization and wasteful services are canceled out by the barrier they present to patients with lower incomes who defer care until they need emergency services, and cutting directly against the state's goals of increasing spending on primary care. I'm confident that in retrospect, the decades-long focus on utilization in health policy circles at the expense of serious attention to prices, consolidation, and administrative waste will be seen as a major health policy failure in our country. For too long, we've focused on mitigating the demand side of the equation, cost sharing, with the real gains for patients and small businesses are to be made on the supply side. To the limited extent that cost sharing may be a part of a future unified financing system, it should not be charged to the patient at the time of care just like what Catherine was saying. Cost sharing another really important point is that cost sharing must also be balanced with much, much greater transparency than we currently have, so that patients can easily assess costs and benefits like they can for almost any other good or service in our economy. Thank you.
Thank you, John. The next person who raised their hand is Ronnie Shur.
Hello, my name is Ronnie Shore, and I'm a retired pharmacist who volunteers as the president of Healthcare for All Washington. And I wanted to urge you to vote in favor of a motion that's on your agenda to really establish clear actions during the meeting. There's a lot of work that this advisory committee really needs to take, and identifying the issues you're going to vote on ahead of time and making motions and taking action is really important. It's good to see you bringing that to the agenda, and that should help clarify or help move forward a lot of the actions you've been contemplating or discussing so far. So I urge you to adopt that policy. Thank you.
Thank you. I am not seeing any other hands raised. If there is one raised, well, please let me know. Or if anyone else would like to speak, now's the time.
I show no other hands raised.
Okay, well, thank you all very much for your comments. And Pam, I will turn it back to you.
Thanks, Mary. Thank you to everyone who took the time to comment. It's a really important part of our work. This next part is really relevant to the last speaker, which is our decision-making process. If we can go to the first slide. So actually, we do have an established agreed upon process, which is that we do make formal motions and seconds and followed by a voice vote. We call it a consensus process, but this is, our formal way of making decisions, and those are recorded in the meeting summary. But next slide. But for whatever reason, and probably lots of different reasons, there has been confusion about some of the actions that we have taken because there has been maybe a lack of sharpness and clarity when we finished up the discussion. Some of this is the nature of the topics themselves, and some of it is running out of time in our own processes. There's also the handoff between us and the commission and back to us again that also sometimes creates confusion. So people may, almost in a game of telephone, have lost track of the original concept. So whenever possible, what we're doing now is, as we are making decisions, to make really sure that we are codifying and documenting the decisions that we have made, even if they're in kind of a formative part of a recommendation and not a formal decision yet. And then motions, votes, and results will be more clearly called out in meeting summaries. And I think this will help us as committee members, but it'll also be helpful to the people who closely follow our work in the general public. Are there any questions? I don't think we need a formal action because the intention of this is just to sharpen a process and make it clearer how we do our work. I see one hand up. Is that Roger?
It is. Thank you. Thank you, Pam. I would encourage, to the extent possible, when there are decision points with FTAC and of course with the commission also, that those be identified in the sort of the forthcoming agenda. That's made available, obviously to the members, but also to the general public and stakeholders, and that be made available in a timely enough fashion where stakeholders in particular have an opportunity to weigh in on the specific items or decisions that are before, FTAC or the commission. I sometimes look to the model that Peb and Seb have been trying to do that I think to a degree accomplishes that. And I would encourage us to develop that structure also. Which
Oh, go ahead.
No, please.
I was just going to say that I was going to thank you for that comment. I think it's a really important clarification. I think today's testimony is a really nice example of that. When people see what's on the agenda, it gives them an opportunity to comment specifically on the topic that we'll be discussing, and then we can hear them before we have the conversation. So we are going to be talking about cost sharing today, and a number of the speakers actually address that specifically. So I think that's an excellent illustration of your point, Roger, and that we can make more of an effort to, I think today's meeting is a good example of that, more of an effort to call out specifically what the intentions and goals of the meeting are to discuss. And as I go through the agenda, I also am kind of trying to make more of an effort to kind of explain the why of topics that appear on the agenda and where we're headed with those topics.
Thank you.
Yeah. Anyone else? Okay, thank you. I think we can go on to the next topic, which is tab 5, and we're going to go back to Liz Arjun at Health Management Association. She's going to update us on the 2024 work plan. Liz.
Hi, everybody. Good to see you all. And thanks for all the comments that were offered relevant to today's topic. I just want to take a minute to ground everyone in where we are, because it's a couple of months since we last met. These meetings are not every month, so I think it's just important to recap how all these pieces are fitting together. So this picture visual is really intended to pull out the phase 1 work, which we've been engaging in for the universal healthcare system. And the check mark indicates what we've gotten through. So as you all may recall, last year, we spent the whole entire year talking about eligibility, just in terms of which populations would be in and out of the universal system in terms of designing the core program. The other pieces related to that, in terms of coming up with a financing estimate, are looking at benefits and services, provider cost reimbursement and participation, and then cost containment. And then all of those would roll up into some type of cost estimate, and then we'd move to the financing. So that's how we've been sequencing all this work. But just to make it a little bit more tangible, we can go to the next slide. And remind folks, but what we did decide, I think, Roger, you had a really good point here. We determined the eligibility for the foundation of the universal healthcare system. And for now, the recommendations or that FTAC made or summarized in a memo in different points to the commission included that for now, the universal healthcare system with uniform financing would be designed to include those in Medicaid, those in individual market plans, small group markets, fully insured, and the uninsured. This was, not the gold star that we all wanted in terms of like rolling everybody into the same package, but this was a question around feasibility for what we could actually get done now. At the same time, we decided that the commission decided that self-funded plans and Medicare would sort of be on hold for now. We would continue to explore the possibility of rolling them in the future. And in the meantime, designing the program and getting it up and going and show that that this is an appealing program and knows what it's doing to help make the case to the federal government to hopefully eventually approve waivers or legislation to allow those two populations. But in the meantime, we're focused on the top bucket. So let's go to the next slide. So this is where we are in terms of cost estimates. So this is related to the slide I showed first. And I really want to thank David DiGiuseppe for walking us through a couple of months ago around kind of how that looks from a health plan perspective. And this is our attempt to really kind of try to boil it down to the different steps that we're doing to come up with a financing package. And here's where we're at. So we've selected benefit packages to model that include the existing assumptions. And I know there was a comment from Roger about that, and we can talk about that in a couple of minutes. And then we will look at different assumptions on that would make a difference in what the cost would be, including cost sharing, provider reimbursement, and cost containment. And so we're refining that cost sharing piece today, and then we'll begin discussing the principles about what that might look like that we want to put forward to the commission. Ultimately, those pieces will be used by Milliman to come up with the cost estimate for the universal healthcare system. And then ultimately, we plan to use that to figure out what does financing look like. So that's just kind of the stepwise approach in which we're taking this. And I'm just going to pause really quick and see if there's any questions before we move to the next part of the meeting. Sure, Roger.
Yeah, thanks, Liz. And this may be part of the next part of the meeting when we're talking more specific in interaction with our actuaries. But let me just say it now, then we can touch base with it. In my view, and they're illustrated here in the development of a benefit package, service benefit package. There are, as what are kind of identified here, at least in my mind, 4 steps. One of those is the identification of the services to be in a benefit design. And I think what we, FTAC, have recommended, and I believe that the commission has approved of, is going forward with modeling 3 benefit designs, if you will. The
Cascade.
silver
Yep.
plan from the exchange, UMP, or I'm sorry, SEBPay, we'll talk about that later, and Medicaid. So what I'm hoping that we can develop out of this actuarial analysis, so we have those as a series of service packages with an associated, PM per member per month cost and what the differences are across those. I think it's important then to keep each of these following steps as distinct and separate ones. And that is, we then identify a set of cost sharing options. And those cost sharing options get tested, if you will, or analyzed against the 3 different service benefit designs. And then at some point in time, let me back up on this thing. I'm confusing 2 things here. When we're doing that initial benefit design comparison, I'm hoping that Milton is going to bring forward a reference pricing to use in the analysis. I guess I'm really trying to get back at, so that what we're seeing in terms of the services are the differences in services, not because of payment structure or not because of cost sharing structure, but the services unto themselves. Similarly, with the cost sharing aspects, it's sort of a matrix. And then, at some point in time, we introduce a decision around, well, what pricing might we be using in this benefit design? And that's a 3rd distinct step that needs to be shown in the analysis, and those then being able to present it to the commission so that they have a full appreciation of each of these steps and the implications thereof. All of a sudden, I'm finding myself not being as clear as I would like to be, but am I making sense on these distinct step notion?
Yes. Let me make sure that I'm recapturing the way that I hear what you're saying. So step 1 right now in the far left-hand box, we're talking about kind of status quo benefit packages as a starting place. Step number 2 is layering on the different variables in the 2nd category onto what you all eventually recommend and settle on. And we're going to spend time on each of those individually and coming up with principles to share with the commission that they can then apply for the 2nd phase of work. Does that make sense, Roger?
It does, and I think at some point in this matrix, because I think they're going to have to see this at some point in time in its totality.
Yeah.
Again, here's service benefits just as they are. I mean, those 3 plans, no cost sharing involved in that. Standardized rates using, so we see the benefit implications, PMPM.
Yep.
We have another, we're creating this matrix. That's a column, and then across there, we have a variety of cost sharing options, from none to whatever we all come up with. And they see the implications of that on a per member per month basis. What's the implications of that? And then, obviously at some point, when we're doing that to some degree, we're having to, I think, use some sort of a standardized rate structure to look at that. So we're not compounding the differences in the rate system that comes forward with each of these plans. And then with that last step, then, bring on what you're talking about there, the provider reimbursement. Because if we don't do that, I'm just going to close on this, spend too much time. Cascade care can be distorted to a degree because it's a public option. So it's got reference pricing in it. PAB and SEB, in theory, do not. And of course, Medicaid has its own family of rate structure. So we need to keep that piece out of it at first when we're going across this comparison, so we don't complicate the decisions we're trying to make in each one of those cells. So thank you for listening.
Yeah. Anything else before we move on? I think we're on the same page, Roger. We need a status quo of what we've selected already. And then we're going to talk about these different variables as a group and come up with some principles for each and give them to the commission to then ultimately say, what are we layering into our selected benefit package? How do we how those pieces apply?
Thank you.
Okay. There'll probably be a better visual next time. Thanks for this conversation. So, all right. Should we move on?
Sure.
Okay.
Okay, I really like that visual, Liz, by the way. It works for me. So I think this next topic will be, really kind of directly responsive to some of the issues that Roger raised as well, in which we're going to be talking about cost and cost sharing analysis. And I think Mary is going to walk us through this initial discussion with maybe some assistance from our colleagues at Milliman.
Yeah, thank you, Pam. And yes, cost and cost sharing analysis. If you think about the previous slide that was just before this one, Liz's green rectangle on the far left, that's where this conversation is happening, the cost sharing analysis. I thought I would start with, this is verbatim from what's in the notes from the July 11th meeting. This is where we landed, what was voted on. And I think at the time, there was the understanding that this ask would be refined, that we would be going back and forth with Milliman to figure out a little more specifically, what the ask was, what the analysis would be. But I thought I would start just with what it says right now in the notes. These are the same three plans. Roger, these are the three that you just mentioned, the three that we are modeling. And then we're also talking about cost sharing options. So there's a little more, if we go to the next slide, begins to break it down. Look at it in more detail, more scenarios. And this is where I'd be very happy if Peter wanted to jump in. I can start us off. Looking at the three scenarios, again, those are the same three plans in our left column, Medicaid, PEB, SEB, Cascade, Silver. And then looking at different cost sharing structures when looking at those benefit packages. So for each of them, that middle column, the cost sharing principles and the cost sharing structure that's being applied is the existing cost sharing structure. So when we look at the people we have defined as the eligible population, the selected population, what is the per member per month for PEB SEB? We also would apply the existing cost sharing for PEB SEB. I hope I explained that right. And I hope that's clear to folks. I also want to clarify, in some earlier language, I think we said the entire population that would be covered by a universal system, and it was construed a bit to mean the entire population. What we are talking about is the population that Liz described a few moments ago, not including Medicare, not including ERISA. So, okay, I see some hands up. And I will just pause there because perhaps I'm not explaining it clearly. So we'll start with Roger. I think your hand was up first.
Christine, you want to go first?
Go ahead. It's fine. I can wait.
Okay. So, Mary, I'm troubled by this, and let me tell you why I'm troubled again. When I look at the scenarios, we got Medicaid, SEB, PEB, and Cascade. The next one over says, okay, now we're going to look at these with the existing cost sharing structure that exists. And when we do that, that doesn't give us a clear picture of the, lack of better words, the actuarial value of each of the service packages. Because they're distorted by Medicaid doesn't have any cost sharing. Cascade's got the subsidized structure that it has, and PEB and SEB have their own. And it doesn't give us a clear picture. Now, having said that, if I jump over, I mean, I'm understanding this myself now. So that's my concern. We're mixing two pieces that does not give a clear picture to either to ourselves or the commission.
Okay.
Because we've introduced these other factors already that distort what that's going to look like.
Okay.
Am I making sense?
I'm sorry, go on.
Please.
No, I didn't mean to cut you off, Roger. Did you have?
Nope.
Okay. I am going to invite Peter to jump in to help clarify that analysis. Peter Hallam from Milliman.
Sure. And I think the first thing that I'd say, and this might be address your concern, when we talk about the costs that are associated with this program, I think that we could provide, both the sort of what we would call allowed cost. So that would be the total cost for services. And then also the cost sharing reduced cost, and what we generally refer to as like the payer paid amount for services. So that should at least remove the, I guess, the direct impact of the cost sharing from the results that we share. However, that's not to say that, benefits held constant, and by that I mean what services are actually covered. That does not mean that the allowed costs under each of these scenarios would be the same. So there would be impacts associated with different cost sharing scenarios, even across the same population. You can imagine even small changes in utilization across emergency and urgent care, for example. So there would be shifting in that, what we would call allowed cost, but it would not include the direct impact of cost sharing amounts. Does that make sense what I'm saying?
No, it doesn't.
Okay.
One more time, I'm sorry.
Okay. I guess what I would say is there's a medical cost that's that we intend to report that includes all payments made to providers for medical covered benefits. I see I've got like 3 hands up now, so I might have to pause this conversation and give others an opportunity in case they've got something to say. But we report on the total cost for medical services under each of these scenarios. That would include both the amounts paid by whoever is carrying the bulk of the burden, say the state, for these covered services, as well as cost sharing amounts. A separate amount that we would also report would be the amount paid by the state, reduced by the cost sharing burden paid by the consumer or the patients. Does that make sense? So both of those numbers will be reported in all 3 of these scenarios.
So one last thing, I'll shut up, Peter. So, because I think it's really important, in that one column where cost sharing is incorporated into it. So it's, it's the full payment, if you will, absent who pays it what portion. The commission's going to be able to say, here's what Medicaid looks like on a PMPM basis, right? This much. Here's PEB, on a PMPM basis, and you would analyze, here's why some of the differences are. And likewise with Cascade, or essentially it's the health, the essential health benefits. That's what each of those looks like, not distorted by cost sharing or price differentials, because they're going to need that. They're going to have to, at some point in time, they're going to have to say, you know what, we're not going to do Medicaid, everybody knows that, but we're going to make a discussion about, PEB SEB, should that be the recommended one we have, or should it be a Cascade Care? And they need to make that absent the distortions that will come out of the cost sharing, because that's a separate set of decisions they're going to have to make. Am I making sense about that?
I think I follow you, but I would caution you that there's not. Unfortunately, these things are interrelated, so it's not as though you can wholly just say, for example, here's the scenario that we like under a benefit structure, and then modulate the cost sharing without actually thinking about what the overall impact to the reaction of the consumer is,
Yeah,
basically.
no, I understand. Yeah, no, right. I understand that. Yeah, absolutely. I didn't imply that. Yeah,
Yeah,
absolutely.
yeah. I just want to say it's not, can't be, those two things can't be totally pulled apart, albeit we will report numbers. I think on like sort of both ends of that spectrum if we're speaking the same language, i.e. the whole allowed cost and the cost amount reduced by patient cost sharing.
Okay. I think we should move on to other questions, and that might be helpful.
Yeah, Christine?
Yeah, so I had more of a clarifying question about trying to understand this this table. And as I've been staring at it, I think I have a better handle, but I thought maybe I would just say what I think this is showing us to make sure that I follow everything. So we're modeling 3 scenarios. The first, and they're represented in the rows. And so one is everybody gets Medicaid cost sharing. So that's basically 100% actuarial value plan. Then we have PEBSEB, where people who are currently eligible for Medicaid retain the Medicaid cost sharing, but everybody else gets the PEBSEB cost sharing, which I assume is kind of like a gold plan. And then 3, we have Cascade Care Silver, and that is where we have Medicaid cost sharing and everyone else gets a silver plan. And I'm assuming that's not including CSRs. And then I noticed there's a note down here which leaves off the small group and fully insured market, I think. So I wonder if that's a mistake.
Addressing the last thing first, yeah, I think that this should also include, this was just an example list. I think it should also include non-ERISA, essentially.
Okay. Okay. And then is my interpretation of the scenarios correct?
I think generally, yes, there could be some nuance around the sliding scale for the silver plan benefits. I guess, to be frank, we haven't gotten down that far in our modeling to know exactly how we're going to be reporting on that.
Okay, so TBD whether the CSRs are a part of that or not.
Right.
Okay.
Got it.
Thank you. Kai, did you have a question?
Yeah. I have two questions or comments. One is that it occurs to me that like one thing that would be very simple to include in this report that actually wouldn't require hardly any analysis, but that would be very helpful is essentially a scenarios 0, right? Which is the current state, right? Like Medicaid with Medicaid cost sharing for Medicaid enrollees, PEB/SEB with PEB/SEB cost sharing for PEB/SEB enrollees, and so on, just so that we know when you show scenario 1, 2, 3, what is sort of the incremental spend in each of those scenarios. That's comment number 1. Comment number 2 is around cost to whom. I went forward a little bit to just skim through the slides, and I didn't see this, but it occurs to me also that it'd be very helpful when you break down these cost scenarios to know how the incremental cost changes are changing for the different parties, right? Patients out of pocket, purchaser, but which purchaser, like fully insured, employers, Medicaid, and in each of those scenarios, I'd imagine the spending would change. The incremental change in the spending would be different for each of the scenarios. So modeling out specifically how those changes for the different parties, I think would also be helpful.
Thank you. And David.
So Peter, thanks for putting this together. I'm anchoring back to the green slide that Liz had, and I think some of the thoughts that Roger had. So one question for you, the population that you run through scenario 1, scenario 2, scenario, it'll be the same population in each scenario. Is that correct? Okay.
Yes.
Okay, great. I'm wondering, I think what Roger was getting at is, could you show first the total cost of care for each scenario for the entire population with no cost sharing? And I'm asking about that because I think when you impose cost sharing on the non-Medicaid enrollees, your explanation of allowed and paid makes sense to me. But I think the allowed under scenario 1 with cost sharing would be different than the total cost of care under scenario one without cost sharing because of induced demand, things like that, inability of people to access certain services because of that cost. Does that seem reasonable to you? And would it make sense to you to run a column that's total cost of care without cost sharing before you split it out into these two columns?
So yeah, I think that's our intention. In fact, our intention at present is to provide the total cost of care of the populations combined and not to break these out separately per se. We're doing this to illustrate that we recognize, that we're not going to be applying, silver plan cost sharing to Medicaid eligibles. Yeah, that's
okay.
So this is more illustrative rather than how we would present results, which would be on a combined basis.
Okay. I think that Roger would address the point that you were trying to make and would allow us to isolate the difference in total cost of care simply from the benefit designs before we start overlaying cost sharing.
It would. Thank you.
Okay. And then Peter, next question, which I think is also something Roger was getting at. What cost per service are you going to use or start out with in each of these? Well, maybe said it another way. Are you going to use a fixed cost per service across scenarios? And what would that be as a starting point?
That's a good question. And so just to make sure we're talking the same thing, or talking the same language, you're talking about provider reimbursement effectively.
Correct. Yes.
So that I think is a question that we wanted to bring up on the next slide. Thank you.
Okay.
I guess I'll pause. Let's come to that in a moment.
Yeah, that's fine. Thanks, Peter.
Yes, thank you, David, for the clarification, and thank you, Peter, for jumping in. And Eddie, your hand is up.
This is a quick question. When David was speaking, it just occurred to me, I just wanted to ask. So when you were talking about the cost sharing, this is on the spend side. You're not changing the denominator of the equation to factor in less utilization of some sort.
So there would be some impact of induced utilization. So in scenario one, I would expect a different utilization pattern than in scenario two, for example, because of, as David put it, folks are going to be responsive for better or worse to cost sharing impacts, right?
So it is going to reduce the usage or the user count in some fashion once you implement cost sharing.
It will shift utilization at the very least, but yes, I would also expect a reduction.
Okay. Thank you.
Thank you, everyone. And I know one of David's questions is going to be addressed on the next slide. So how about if we move on, we go to the next slide. There we go. Was your question about provider reimbursement, David?
Yes, thank you, Mary.
Okay. Modeled at rates that approximate overall payment neutrality to medical providers for individuals enrolled in the program. Milliman will rely on information from HCA, estimates of commercial and individual market reimbursement rates, and historical enrollment and utilization patterns to estimate these rates. I will pause and let folks read the rest of this, the assumptions behind the analysis. And David, I don't know if you want to repeat your question or if you have other, your hand is up. There we go.
So Peter, when you refer to payment neutrality, it sounds like you're going to blend or weight current Medicaid reimbursement rates with commercial reimbursement rates to come up essentially with a new fee schedule or unit pricing that you would then apply in the model we're talking about.
Yeah, I'd be really careful about saying fee schedule or going down to that level because that is not our intention. So what we would do is blend the reimbursement rates on some sort of normalized unit basis.
Okay.
And come up with something that we think would approximate payment neutrality. And what I should be very cautious about here is we are not going to make any assumptions around how the shifting of services would cause that payment net neutrality to essentially be skewed across providers. So, if you, I talk in extremes a lot because I think it's an easy way to illustrate points. If you stop covering any services except for inpatient services, and then calculated payment neutrality based on the current utilization basis, that payment neutrality would not expect to be borne out because you would expect folks to use inpatient services more and other services less. So,
Yes.
So I don't want to pretend that we're forecasting or projecting what would truly work out to be payment neutrality, but we would take historical reimbursement rates, and as we blend the populations, I'm speaking without having done the analysis, you might expect some increase in reimbursement rates to what was the Medicaid population and a decrease to reimbursement rates to what was the commercially enrolled population to get to a neutral payment through the point across that entire new group of people. Does that make sense?
Yes, it makes sense. If I can, I'd like to just validate my thought about what we can do with the results based on the method you described. So tell me if this is right. It'll allow us to see the cost impact to the state of covering more benefits or fewer benefits across the three scenarios. It'll let us see the cost impact to the state and to covered beneficiaries of either having zero cost sharing or some cost sharing. And maybe even more importantly, it'll set us up for the cost containment conversation because it'll give us some kind of estimate of cost to the state that doesn't exist today, such that we can tee up the conversation of what sort of supply side cost control mechanisms might we want to discuss next to bring down the overall cost to the state of a unified system. Is that a reasonable way to think about it?
Yeah, I think it is. I mean, I will throw out the cautions of this is going to be a very heavily Medicaid. This population is going to be very Medicaid heavy. So there's going to be a lot of weight on that reimbursement level. So the results that you pull out of that, I guess I would, the reimbursement rate will probably be mostly reflective of Medicaid reimbursement. I mean, there's going to be some other populations there, but just I guess I want to preface that might have impacts on downstream discussions.
Okay, that's a good point. Thank you.
Thank you for that clarification, David and Peter. And Roger and Eddie, I do see your hands. I just want to make one comment before you do that. Also, just to remind people that we're still talking about the far left rectangle that was on Liz's slide, that we're still, the cost estimate and the cost sharing. And some of the other pieces, David, as you point out, will be later on later. And, this is to lay the groundwork to work toward those other pieces. Eddie, I don't know if you meant to put your hand down, but Roger, your hand is still up.
Yes, I'll try to do this quick again. So Peter, what I'm hearing you say, let me give an example, if I might, just be sure I understand. The Oregon Task Force on Healthcare Reform, they came up with a benefit design. It was going to be public employees. And at some point in time, they said, well, what rates are we going to use? And they decided that they wanted to keep this, if you will, reimbursement neutral. So they went through with their actuaries some calculation that said to do that across all these populations, we're going to set our rate structure for that one. I believe it was about 140% of Medicare for this exercise. That's cool. I mean, you're going to do something similar to that, if I understand. And, the numbers will be whatever the numbers are. I would say to all of us, at some point in time, again, ourselves, we're going to be asked for, and the commission is, well, what rate structure should we be using? And so I think we're going to be in a situation where we say, well, we built an analysis, let's say on this 140% figure, just for the sake of discussion, and we're going to, need to do other, political and other types of scenarios. I'll use one example because it's certainly a strong one in our state with Cascade Care that I'm making a little bit more simple. Pam knows better than I do that's at 160% of Medicare, excuse me, you say Medicare. You know, folks say, well, where did that come from? Well, it came from political negotiations. Everybody said we can do it with that. And I'm just trying to use it as another example of price structures that may be introduced later on as we further go through these iterative analysis. I think I've seen your nod your head, Pierce. So I think I'm kind of point. And then one last question, just to be sure. One more time, the population that we're going to be modeling, who is that again? Because you said that Medicaid is going to be heavily weighted. That's 2 million folks, but we got 500,000 or so sub-PEBs. And are we going to use 200,000 from the exchange, 250,000 from the exchange? But are you going to be bringing in a broader population, or are we going to use these that you have access to through the healthcare authority? Am I making sense?
Sorry, I didn't mean to cut you off.
No, please.
So I think there are a couple of questions there. The first one I'll address is the broad strokes of the analysis that was done in Oregon. While I'm not as familiar with that, that sounded correct, as in using a Medicare sort of benchmark to estimate costs. So that is the approach we're intending to use. Caveat that with not all services might follow exactly that procedure. For example, there's no Medicare fee schedule for prescription drugs, and we will be attempting to, come up with some, I think, close to a payment neutral modeling of that as well. Just footnoting that. With respect to your second point, the populations that we intend to include, you listed several of them. The other ones I'd be including would be the commercial population outside of the ERISA eligible plans. So
large group market?
Yeah, so generally, I think it's going to be small group market because my understanding is a good portion of large group is actually ERISA eligible, even when, or ERISA regulated, when it's outside of, even when it's outside of the employer pay. So there's going to be big carve outs there for those, which I assume is mainly because the state doesn't really have an ability to kind of push on those plans.
Yeah.
Did that answer your question?
Yeah, it may encourage, and I know you do that when you do the analysis, because I think when people are thinking about this in general, I didn't see myself as to say, and you've commented, I said, because of how we're drawing this, we're not including Medicare, understand that, we can't get a risk, so I get all that. Your point's well taken. This thing really is, at least in terms of population, is a heavily a Medicaid population. What am I trying to say about it? I just think that needs to be noted in the analysis, which I'm sure it will be. And I'm personally not uncomfortable with that because at some point in time, we're going to have to stepwise this thing into implementation, right? We said it all along, we're not going to be able to get ERISA now, Medicare, that we have to demonstrate that we can do something before they're going to give us it. So what do we have to put our hands around? And I think those that you're outlining here are those, in my opinion, we can. So it reflects, if you will, the first iteration of an implementation of the new system.
Right. One other thing, sorry. I was going to add one other thing that I should mention that I don't think I mentioned is there's not a small uninsured population that would also be rolled in here. And so that's also, I think, from any sort of payment neutral perspective, going to be causing downward pressure on whatever that payment neutral rate is.
Gotcha.
Yeah, thank you. And we have one more slide before we have our wrap-up slide. And this slide, I realize, does now talk about the enrolled population. We should have come here. If we can go to the next slide, please, Audrey. Okay, here we have our enrolled. Whoops, no, back to the previous one. There we go. Thank you. The enrolled population. There are the assumptions about who we are talking about. This is the conversation that Peter was just clarifying. Results would be when it says the entire population there in the second bullet, that means the entire selected population, the defined population, not the entire population of Washington. Some additional considerations down the bottom. Give folks a minute to read those to see if there are any further questions on these. Roger.
Yeah, thank you again. So Peter, another question. I see under additional considerations, the two medical management scenarios. That raises a question to me, which I'm not sure where it gets put. We've talked about benefits, cost sharing. Something that sits out there in medical management, of course, is prior authorization. And that's this whole set of decision makings into itself, as you know so well. Do they kind of get fit into that, if you will, that, lack of better words, the two models of, without getting into any detail now of here's how we're going to handle prior authorization, or we won't just deal with it at all now, which is understandable. So my question is, how do you handle prior authorization?
Yeah. Sorry.
Oh, please.
As of right now, our intention is to, build it into essentially those two scenarios. A PPO-like scenario would have some prior authorization requirements. It would also include things like perhaps a designated nurse line or proactive nurse lines that would call people and remind them to take their medications, things like that, where there is some medical management going on. On the other hand, a fee-for-service like medical management probably wouldn't have those things, or would have very limited prior authorization requirements and probably no, patient outreach for post-discharge services or things like that. So there is a bit of blending there. I don't know that we can really disentangle those two easily, at least in the way we're going to develop the modeling, but hopefully that answers your question. In short, those things will be blended into the medical management sort of endpoints of the analysis we provide, if that makes sense.
Yes, thank you.
Thank you both. Kai, did you have a question?
Yeah, comment. So on point 2 there, where the results are going to be provided for the entire population, not broken down by other cohorts, I wanted to clarify also, so that gets to my early comment about having a baseline and specifically, and then also breaking it down by cohort. So why not, break the results down by cohorts, for instance, like understanding how a scenario 2 or 3 or whatever incrementally affects the out-of-pocket costs for the population, for the pet population, cascade care population, and so on.
I guess I understand the concern there, and we would be modeling at least broken down into our underlying modeling would be broken down into some of these cohorts, but I think there's a complexity in, an added complexity in modeling independently all of these populations sort of, and then adding them up at the end that isn't built into at least the approach that we're taking at this time.
That implies that you will, in the modeling, is it true then that you wouldn't necessarily know for a given current population, beneficiary population, what their change in out-of-pocket cost would be? Your model wouldn't provide that result, right? It just provide an average change in out-of-pocket cost for the entire population. Is that right?
Yeah, if you're talking about specifically the change, yes. If you're talking, we would, however, at least in our supporting work, have some documentation of what we expect their current costs to be. But getting the delta for some, or the change for some specific subpopulation, that's not something we are intending to provide at this time.
Okay.
Thank you for that clarification. David.
First, Kai, I think you're asking good questions, and what I take as the implications of your questions are ultimately when we get to the financing discussion down the road, I think either the commission or legislators are going to want to know what's the impact on a company that's fully insured today, or what's the impact on a beneficiary that's fully insured. So, maybe we just put a pin in that and somehow get back to that when we get to the financing. Peter, I have a question for you, which is, I'm thinking that as we go through this exercise, one of our responsibilities is to illustrate to the commission the total cost impact of different benefit designs, the total cost impact of no cost sharing versus some cost sharing. So I'm looking at the two middle bullets in the lower section where the program and admin costs are excluded and the results being expressed on a per member per month basis. And I'm thinking, does that get us to the point where we could say to the commission, if you have no cost sharing, it's going to cost the state, $50 billion. If you have some cost sharing, it'll cost the state $25 billion.
So I guess I'll take one of those bullets independently from my response here, if you don't mind. In terms of administrative costs, at least based on the information I have now, don't have a good perspective of or understanding what the state would do to administer the system. I don't know if that would be something sort of grown out of the current Medicaid administration system, or if it would be contracting with some other entity to do this. I don't know for example, jumping back to the medical management bullet, I don't know what sort of medical management is intended, nor do I know how that would be implemented. So I think there are enough unknowns there that I don't feel confident that I could come up with any reasonable estimate of admin costs, in short. And so that is a limitation, but not one that I feel like I'm prepared to be able to.
Okay, I understand.
And then two, in terms of expressing as per member per month costs, that's essentially to make it so we can provide you with a number that's usable as projection for some population that you expect would be pulled into this program. I mean, assuming that it would align with our underlying assumptions of Medicaid, et cetera. The idea being that, if you're expecting a pilot program that is drawn from all of these populations, you could estimate that cost, or if you're expecting everyone to be enrolled, it's an exercise of multiplication. Hopefully, again, making sure that the assumptions underlying our analysis agree with the assumptions underlying the population that you're selecting for enrollment. Does that make sense? I guess
yes.
We didn't want to say, for example, forecast population growth in each of these different groups.
Yeah, and I guess it's just for as a group, as we think about delivering results to the commission, if we say, oh, this program is $495 PMPM, this other scenario is $510 PMPM, I don't think that's going to mean much to the committee. Like, ultimately, I think we'll have to translate that into absolute dollar impact.
And we can discuss that down the line. I don't know that. Again, I don't think we would want to be forecasting population growth in each one of these groups, but we could certainly, have a hand in discussing how our numbers would be married with those sorts of projections appropriately.
Yeah. Okay. Thank you.
Thank you. Eddie,
Yes.
do you have a question?
Yes, a comment. But yeah, from what David was saying, I think both of those bullets are. So I want to know what we're expecting to be able to use from the product, and per member per month cost that we can plug in a caseload to, even though you've already kind of come up with the results for the entire population. So I don't know if I'm not understanding which one I'm getting. Is it a total cost for the total population modeled, or is it a PMPM where I plug in my caseload to your final number? And then the other one on the considerations for the state funded part, I think, the total cost versus the state responsibility, is there an assumption of, or are we supposed to basically plug that in? We're assuming, you know, a federal match of 50% or other. Is that what the goal there would be?
I don't know for sure if that's a question to me. I guess I can discuss there is nuance there. I don't know, for example, how the state intends to address, for example, I don't know what would happen to uncompensated care payments under the Medicare program. Should there be no uninsured population in Washington because everyone was enrolled in this program or were enrolled in this program. So I don't have a short answer on this one, but it is something we're not intending to address in our work is the funding sources. So I guess that's a short answer there.
Okay, I see. I just want to understand how to use the model once we get it back, but it's like a rate sheet with a PM that we can then allow ourselves to, like you said, put in projections to the caseload.
That's right.
Thank you.
Okay, thank you. And Liz, did you want to jump in?
Sorry, I didn't mean to raise my hand.
Okay, Roger.
didn't mean to raise my hand either, but I will come real quick because I think there's a good point made here about the program administrative costs. And again, at some point, decisions are going to have to be made about delivery systems. Are we going to have health carriers or not? And if we're not going to have health carriers, is it going to be, state administered? And that has a whole set of, administrative structures to it versus the plans. And I would say this part of the analysis, those to me are all add-ons at some other point along the road when further decisions or at least further model options are going to be asked. So I'm personally comfortable with that, with that structure and that approach. And David, one more time, I kind of agree with you. I keep coming back to this and saying ourselves and the commission's going to have to say, we're looking at this matrix of options, and they're going to be stated on a PM basis. And around each of that cost sharing, there'll be an actuarial value to that. You see how much the patient's going to bear versus, the state of the others. And then, then at some point, maybe it was to Eddie's comment, somebody's going to say, well, that's fine. How much does all this cost? And that's a fair, obviously more than a fair one. I see that as another set of tables. And we said, here they are, here are these there, and get a feel for that. Now we add in, a population estimates, and you can see what the relative relationship of these PMs are on an aggregate basis. So I think we need both of those for guidance to the commission.
Thank you. Pam.
Yeah, thanks. Just a couple more general comments. I think that when I worked on something similar to this many years ago, when we passed a universal healthcare bill in the state, and we did exactly very similar approach. We didn't do the comparison among packages, but we did drive towards doing a PM, and that becomes kind of your building block because there's so much that we don't know. Where we have to start somewhere, but we don't yet know how we're administering this, as Peter pointed out, and we don't really know how we're financing it. So the way to kind of thread our way through those unknowns, I believe, is starting with the PM, because that'll allow us to extrapolate to kind of where we go next. The other thing I want to say, just stating the obvious, is that the commission asked to compare 3 benefit packages. That sounded so simple. It's just incredibly humbling how complicated this is.
Thank you, Pam. And I am keeping an eye on time, so I'd like to move us along to the last slide of this section. The first thing I put in here was questions about the analysis and assumptions. We've had plenty of questions, so thank you all very much for the questions and the comments. It really helps shape the work. I guess I could put out last call for questions or move us to our next bullet, which is Milliman has proposed that we identify FTAC liaisons who will be able to work with Milliman on this analysis between FTAC meetings to keep I know these meetings are every other month, to keep the work moving in between the meetings. Things like confirming the modeling, developing the format of the final report, fielding questions as they come up. So I do want to throw that out to the group. That was Milliman's proposal to see how committee members feel about that. And Pam, I don't know if this needs an official vote or if this just needs a decision of this is how we're going to keep the work moving.
I think we might want to make it official at some point. Some
Okay.
people may want to think about it before they volunteer. I want to note that we're under the Public Meetings Act, and so this would be a small group. It can't be a quorum of the group. And I would strongly encourage people who have some actuarial background and comfort to do this. And we kind of listening to the discussion, not to put anybody like David on the spot, but I think it would be good to kind of bring in that expertise. What I want to ask you, kind of back to you, is do we want to have people contact you or me after the meeting, or if they're interested? And then we could codify this and kind of share the information later. I'm afraid I don't have the answer about needing to take a formal action. I don't see why we would. I think the most important thing is that we communicate transparently about who's involved and what we're doing.
Sure. If people want to, after this meeting, if you are interested in being an FTAC liaison to the Milliman work, please, I would say, send the email to me or to the general FTAC mailbox, whichever one you have. I guess the general FTAC mailbox makes a little bit more sense. And so we can do it that way, reach out and express interest, and then we can go from there. Are there any other questions or comments about that?
From the standpoint of a time commitment, what is that?
Good question. I don't know.
Yeah, I don't think we know that quite yet. That is a good question, though. Peter, if you have a sense of it, please jump in, or that is something we can work on a little more and send out to folks before they express interest to us.
I would say in terms of meeting, I would hope for something like at least setting aside an hour a week.
Okay.
In terms of preparation time, there might be some additional time. We might send out questions that we'd like you to think about or potentially do a little bit of research on. I don't think it would be hours, or I don't think it would be many hours, but it might be a little bit of additional time in addition to the meeting.
Okay, thank you. And I think, Pam, we were thinking of 3 liaisons.
Mhm.
3 or 4, I think, keeps us under a quorum.
Right.
Okay.
And I think 3 people would be sufficient. I mean, given the time commitment, it's a lot to ask of people. I would say in advance, really appreciative of people who can step forward and help with this.
All right, I am not seeing any additional hands. If more questions come up or if you're interested, please feel free to reach out via the FTAC mailbox and we will answer your questions and be in touch with more details. Thank you, everybody. Thank you, Peter. And Pam, I think it's back to you.
Yeah, I think I'm just emceeing at this point, which is I want to comment that it was a really excellent discussion, really good questions, and really appreciate Peter's helping to field all those questions. We're going to continue with the topic of cost sharing, and Liz is going to lead a discussion about principles of cost sharing. And tab 7 of your packet is what you need for this conversation.
Except I'm going to jump in because we missed a hand that was raised.
Oh.
I'm not sure. My apologies for that.
I didn't see it either.
Yeah, it's a whole Washington hand. Is this a comment about our previous conversation?
Can you hear me?
Yes, thank you.
I just wasn't clear. I was kind of futzing with some stuff. you're asking for volunteers for that from your committee to do additional work, because we've got people that I would be willing to help you work with that. And I'm sure we have some others also, but like I said,
That's really generous. I think this will be from the committee.
yeah, that's right. That's what I was wanting to clarify. Okay, thanks.
Thanks for
Thank you.
asking.
And no more hands now, I think.
So back to Liz.
Yep.
Awesome. Well, this has been a really helpful conversation. I think, you know, again, just I always have to remind myself that was like the step one, like trying to get a status quo. And what we're moving into now is looking at the different variables that we're eventually going to layer on. And we had a chance to hear and go in depth on cost sharing back in July. And what we thought would be helpful, and that I think hopefully is in line with how we've been approaching this over the last couple of years now, is to have a conversation with all of you about for the second phase of work, if there is cost sharing, or you know, just a discussion around cost sharing in general in the universal system, and just sort of trying to go through how do we view it in the system? Do we want it at all? If we do have it, what are some limitations we might want to consider? And so that's what we're shifting into now. And we would draft a memo following this conversation, sort of with whatever we come up with as a group around our principles to share with the commission. And then, you know, that would be the lens or thing that we would go to when we get into this to the step two of all this, when we layer in these variables. So that's what we're hoping to at least begin talking about today. So why don't we go to the next slide? And Mary, I just want to make sure, I had seen at some point that we were supposed to take a break. Are we doing that or no?
We could do it now, or we could do it after the presentation.
It's really not much of a, it's just a couple of slides with some starting point conversation. I'm asking the group because are we set to end at 4 or 4:30?
4:30.
Okay.
I'm sorry, go on, Pam.
Do you want to take like a 5-minute break now, so that the only thing I think would be nice is just to kind of keep Liz's presentation, the conversation all coherent, and not have to break in the middle of a brilliant idea. So.
Okay. All right. I know HCA folks, I don't know if are you in the room today? I know people need to move around a minute. So why don't we just do that real quick and we'll come back.
Sure. Thank you.
back. See some faces starting to show up, so you can just give it a second. If you all are back, if you wouldn't mind turning on your camera, shooting a thumbs up so we know that you're here, that would be great. I understand if you're ready to be off camera, but just want to make sure we get the group here for this conversation. Hi, Todd. Did you mean to raise your hand? Oh, you're here just saying you're here. Okay, thanks. Oh, Zoom is so fun. Okay. Why don't we go to the next slide? Here we are. Okay, so these are just some of the questions that the project team pondered as we want to talk about principles for cost sharing, and hoping that you all can really deliberate on these and provide some input and guidance to the Universal Healthcare Commission on this. We heard from folks in July. I'm just going to touch on a couple points to just keep in mind and then pivot to a couple of examples that we know. So in July, our speakers talked about how Medicare is an example of a program that has a lot of high out-of-pocket expenses to finance their program. So their first question really was about being clear about whether cost sharing is a way that we're going to finance the program, or is it for something else? Is it about incentivizing or disincentivizing certain behaviors? I think another piece that they touched on was what should it be the status quo? And I think that's what we just talked a little bit about with the step one process. Or do we want to do something where we limit it by income across all programs? Or do we want to do something different with services? Another comment that they shared was when and where is cost sharing charged? Is it point of services versus deductible versus co-insurance? Some other questions, do we mirror what's already in place? And then again, do we want to do these? It's just a little bit more detail, income sensitive or not, in categories of services. So those were some of the questions that I think they posed to us back in July. But I want to go to the next slide and just share a little bit of background for folks who aren't aware of kind of what's happening in other similar situations or scenarios, just to kind of keep that in the back of your mind. So in the Oregon proposal, there is no cost sharing, but they were actually directed by the legislature to have no cost sharing. So that's very different from what we're doing here. The Vermont model, they focused on actuarial value and modeled actually 3 options, not 2, 100%, which is no cost sharing, 87%, and 80%. And for these other 2 models, these other 2 actuarial values, they included protections for people with Medicaid and exchange plans, but they didn't set any cost sharing. So they just came up with how much the whole thing was going to cost. And I think Anya mentioned when she was here in July that because they had the 100% no cost sharing, that's kind of where everybody got stuck. And it ended up kind of tanking the whole thing because it was really expensive and there was nothing. It was all just going to be funded by a tax or something. And folks from whole Washington, please feel free to jump in here if I've captured this incorrectly. The Health Trust proposal acknowledges that cost sharing is part of most universal healthcare systems, but really points out some of the detrimental impacts that it could have. And so, again, kind of looking at those trade-offs. And then just kind of as a starting place, and we talked about this earlier, PEB-SEB has the same cost sharing regardless of income for every person. And then Cascade Care has a sliding scale cost sharing, which with some additional state subsidies to offset what's in the federal law. And then finally, Medicaid, which has no cost sharing. So I just want to put that out there as just kind of what are we currently looking at, some examples, and really open it up for discussion. And I just want to give Roger some kudos for sending his memo, because I think he started the conversation via email, and just really, we want this to be your conversation, and our job as the staff is really to just reflect back what we're hearing and put something together that we can share with the commission. We would come up with a draft of something, share it with all of you between now and the next commission meeting, and then share it with the commission and then come back. So that's that's my part. We can take down the slides. I know Mary's gonna be taking notes real time so that we can try to capture everything that we're hearing. And Roger, go ahead.
I think you're on mute.
Thank you. A proposal to the committee. I think the notion around a set of guiding principles, I would much support and endorse. As a precursor to that, I would like to suggest that we make some agreed to sort of statements about cost sharing. And by that I mean is, what do we know from the literature? What does it tell us about cost sharing? Does not do. And I think that's important because that helps us frame how we're going to structure what might be our guiding principles. I'll give a simple example, if I might. Then I think that the literature is pretty compelling to say that does cost sharing have an impact on utilization? I think the answer to that, without question, is yes. So let me just say that for just a moment. So that may lead us to saying, well, if that's the case, and we want to promote, good whole health in our state, then we may not want to consider cost sharing on preventive services or primary care. I'm just trying to use that as an example. That is from the statements that we know about cost sharing to help guide our guiding principles. And in my memo, I plagiarized, I took it right out of some summary work that from RAND, from their health insurance experiment. I mean, sort of the 5 things that they found from that. And my view of reading the cost sharing literature, as many of us have, it essentially, reaffirms what the health insurance experiment found. And that something like that might be serving as a basis for, statements about cost sharing. So I offer that for consideration.
Pam?
Yeah, I think Roger started out in the right place. I think that the issue of cost sharing being a barrier to care is a really important thing to address. And I think it's not going out on a limb for this committee to say that, as a principle, that cost sharing should not be a barrier to care or a barrier to seeking care.
The other hands. Unless there's another hand up, but I'm not seeing. Oh, here. Christine, yeah.
Yeah, so I just wanted to, my understanding of the RAND health insurance experiment is that it was a barrier, but where there were adverse effects was really for the low income population. So I want to keep that in mind that, it does seem detrimental to the low income population, but we might want to consider whether it's valid or something that would be useful for the higher income population, if only because of those stories about Vermont and the, Medicare relying on it as a means of financing the program, that we, while it would be nice to not have cost sharing, it might be something that could help this program to be more viable.
Yeah.
Other folks? I like Christina, you're mentioning that it should be something that we do keep in the back pocket or something that we keep on the table in terms of how to finance something, but also recognizing that the impacts that we're talking about are felt stronger for folks with lower incomes, and we need to come up with some way for protections. Okay. Roger?
Yeah, let's speak. I'm sorry to keep doing this. Let me make 2 suggestions again. One is, I think we're being asked to develop a series of cost sharing options to provide guidance to the commission. And my humble opinion is that's everything from no cost sharing to cost sharing options. We're going to provide to them an array of cost sharing options. And I think we should be comfortable with that, not necessarily say we endorse any of those things. We need to see what the impact of all that is. So I just would say to us is, yes, we've been asked to look at cost sharing. Yes, we will. And among the options, I can hear Vicki Gold saying to me now is one model with no cost sharing.
Yep.
So now the other would be is, Liz, I'm sorry to keep this. Do you have access to that memo that I sent?
I do. Do you want me to share it? Is that what you're concerned about? Or Mary, do you have it?
I do have it. If you give me a moment, I can find it. Do you want me to
Sure.
share it?
Yeah, would you please? It maybe captures what I'm trying to share in terms of statements about cost sharing that can help our discussion about guiding principles.
Yep, it's going to
Okay.
take me a minute, but I'll get there.
Why don't we go to, I can't see who had their hand up first, Eddie or Kai, while Mary works on that. So go ahead, Eddie.
Kai did, but
Okay. Kai?
Okay, yeah, still processing, but here are my few initial thoughts. One is, I do agree with the assertions around utilization and low-income population, but just to also add, with the more recent Oregon health insurance experiment, that even in the sort of Medicaid population, the direct impacts on physical health are non-clear, right? And so that's one assertion. Two is I want to make the assertion that uh, I understand that we are keeping the modeling of cost sharing and provider reimbursement separate. As I agree with that, but I think that at some point they'll need to be combined. And I think the assertion that I want to make, at a later stage, right, is that I think the principle could be that you keep cost sharing as low as possible to achieve some budgetary whatever scenario, right? Which then is subject to, of course, your rates of provider reimbursement. So the two are sort of viewed on a sliding scale, and there's various different options, right? Where one could increase and the other decrease, and so on, right? Three is a nuance to consider is increasing access to utilization of what. And so that's where this sort of value-based benefits comes in of varying cost sharing based on the expected health benefit of the given service. And so I'm a little bit conflicted about whether or not that approach has a place here. I've done a lot of research on that approach and I understand the merits of it, but it does add a substantial degree of complexity in administering the benefit and deciding what is of high value. Briefly, what is of high value on average for a population may not be for an individual, and vice versa.
So more targeted approach. Okay,
Yeah,
targeted on the benefits or categories. Cost sharing only applies to certain places.
Right. Yeah, varying the cost sharing based on the expected clinical benefit of the
okay.
Yeah,
and the second one was keeping it as low as possible to achieve
some budgetary goal, right?
Okay.
Acceptable budgetary impact, right? Which then implies, of course, the provider reimbursement piece. They're kind of like two sliding scales, right?
And what was the first one? I'm sorry, Kai.
It's actually, so to me, it's actually not super clear from the literature, right? And I'm quite familiar with the literature, what the health impact, even in the low income population, of cost sharing is. With it's conflicted actually with the Oregon Health Insurance experiment, showing that the physical impact within the first few years is no, right?
Great, thank you. Eddie.
So I was just looking at the bullets, and so from the work we're getting from Milliman, we're ultimately getting a PMPM. We're not getting a kind of fee for service, so the cost sharing is not related to meeting a deductible or a sliding scale of a certain benefit up to an out-of-pocket maximum. We have a PMPM. So that bullet that's when is the cost sharing charge as a point of service, deductible, co-insurance? Don't we know this, or am I just oversimplifying things?
We know it for the status quo, and we're talking about hypotheticals for what we would want on our universal system. So does that make sense? And Peter, I think you're here, right?
Sorry, I have a fan going because my office has gotten quite hot.
It's okay.
So I think, yes, we do know that for the status quo under the several benefit and cost sharing designs that we discussed earlier. I guess the question, it sounds like you're addressing though, is what you might select in some future state that's outside of specific modeling scenarios we're discussing.
So really the mechanism, the point of service is the mechanism for your cost sharing piece. And if there's means tested in some fashion, that would address, I guess, the population mix by income.
That sounds correct to me. I mean, I don't think this question is necessarily too.
Okay, got it. Well, thank you.
Pam?
Yeah, I'm kind of in some ways I'm friendly amendment to Kai's comments. And true confession, I worked at Group Health Cooperative for 16 years. I've thought a lot about these issues. And so I think that there's a principle there in terms of health promotion rather than value-based, which we think of benefit design or the insurance company's perspective. But promotion of health can also be from more of a consumer perspective as well as a community health perspective. So this is where not having cost sharing on preventive health, not having cost sharing on family planning, things that are, you don't ever want to have any kind of a barrier to chronic care is another one where you can administer, plan, benefits so that you really are encouraging people to seek those services. So I think that I'm not exactly sure how we word it, but I think I would encourage that to be a principle.
And Mary, just FYI, I'm trying to take as many detailed notes as I can so that you can put it into your.
Thank you.
Yeah. Eddie, is your hand up again, or do we need to rate? Okay, thanks. Okay, Roger, where do you want Mary to zoom in?
If you could go to page 2. Yeah, right there. That's right. That's great. So my suggestion back again to set the structure for our guiding principles is to make some, lack of better words, declarative statements about cost sharing, ones that we're comfortable with. And in my memo to you, I use these 5 as an example, and to my colleague at RAND, they're straight plagiarizing from the work from RAND, which is still the godfather of all this, or godmother. These 5 points. Now I'm offering that something like this would be part of our development of this memo that Liz Mary be working on, is saying, you've asked us to look at cost sharing. Here is the sense of what cost sharing does. People may say, well, isn't this all self-evident? And I'd say, well, it probably is to all of us. We live in this world. Of course, we all have our opinions about it, but I think these an example of what cost sharing can do and can't do, and would offer those as a set of statements about cost sharing that sets the stage again for our development.
Okay. That makes sense. Let's go to Christine, and then Mary, do you want this to stay up, Christine, while you talk, or should we put it back on the notes? Is that okay?
No, the notes are fine.
Okay.
I just had a sort of clarifying question for Kai, and also in response to Pam's comments. There's there's something called value-based insurance design, which is where you have lower cost sharing for specific drugs or treatments for people with specific chronic illnesses. And Kai, I'm wondering, when you said the complexity, I'm wondering if you were referring more to that versus Pam's suggestion of sort of just no cost sharing or reduced cost sharing for general preventive services that would hit everyone. Because I'm thinking the complexity maybe coming in when it's so targeted that it's like a plan within a plan situation in terms of trying to determine who's eligible for the benefit versus the Pam scenario of the benefit is there for everyone. And I wondered if you could comment on that.
Yeah, thank you for opportunity to clarify. Yeah, I think you're right that that nuance is important and there's gradations there. I think that like a little bit comes just from like say, I spent some time in the UK, which has some notion of universal coverage, and there like I think when you have a universal payer, you are gonna get like substantial public debate around what's covered and what's not covered. I think that same gradation is going to happen for coverage in a scenario like this, but then also on how much something is covered, right? Whether it's zero versus $50 copay. Like there's going to be interest groups that would want to cover their particular intervention service drug in the zero copay category, right? So there's going to be some deliberative process and complexity added as a result of that. But you're right that like that can be simplified if you I don't know, have just two simple categories of zero copay versus some X flat copay for everything else. And but there's still going to be some complexity from that. I don't know if that helps. As opposed to like multiple steps where I've also done research on that, like
Right. So
multiple steps of copay.
It sounds like just a tiered copay adds complexity, and that it would really probably add way more complexity to have not just tiered copay, but targeted to different individuals based on their specific
Targeted individuals or targeted towards the average effect of that intervention.
Okay.
Right. Yeah.
So just backing up a second, I really appreciate you all you probing a little bit more, Christine. I just want to go back to Roger's question and just check with the group is the group comfortable with the principals having sort of a prelude or an intro part that focus on the fact that the commission or FTAC acknowledges that cost sharing can have an impact on access, utilization, and that it's not. So just to acknowledge that, I just want to ask if we want to have a principle that spells that out and acknowledges it and sort of says that, with that in mind, we then talk about if it is going to happen, what it should look like. So I just want to stop for a minute and ask that question. Pam and then Roger.
I think I got distracted by your questions.
Oh, sorry. I'm sorry.
No worries at all.
I just was going back to Roger's declarative sentences. Do we want to have a few declarative sentences?
I appreciate you're trying to corral us into having something that can be a document. So I think that is a good way to start because that does seem to be the foundational principle. I think the other thing I was going to respond to was the conversation between Christine and Kai about tiered benefits because they are complex, but they are a reality. It's particularly in pharmaceuticals. It's hard to imagine any plan that is not, under a tiered benefit design. And there's lots of reasons for it. Some of it is to encourage people to make better choices.
Mm-hmm. Okay, Roger.
So Liz, I would encourage us rather than make our own statements to look at those 5 from Rand and see if we can vote now that we're comfortable with. I think they cover a wide array of nuances. I mean, it's better than just saying, cost sharing has some adverse impact and it saves money. I mean, that's the two we always go back to. And I think, again, I'm arguing that these are a fairly rich set of nuanced impacts of what the research shows. So I'd rather trying to
recreate the wheel
like this, and I would encourage. The other thing, because I think Kai raised an interesting one. This is with respect to Medicaid. I'm going to warn you for just a minute, and please bear with me. At some point in time, if we go forward with this universal system, we're going to be asking CMS for a Medicaid waiver. It's going to be an 1115 waiver. That's the pathway, and it does exist. However, depending on the administration, they can be very leery about both premium obligations and cost sharing for low-income persons otherwise eligible for Medicaid. And depending on the administration, I can assure you, that could be a real problem area. Now, my only point of bringing that up, and I don't want us to talk about all the complexities of the Medicaid rules on cost sharing this time. It's fairly arcane. I think the point would be is we need to keep that general concept in mind, both for low income people and the Medicaid constraints, and not that it limit what we're doing now, but it remains as a marker at some point is to say as we design the system, how are we going to navigate those set of relationships with CMS? That's the one area under a Democratic administration, as Pam and I can attest to, they're going to be very, very diligent about as opposed.
Well, and just to kind of point out and I didn't touch on this, but in the Vermont model, and it's similar to what they're modeling for status quo, Medicaid is going to had no cost sharing. The cost sharing protections that folks had in Vermont maintained. They were for people in Medicaid and for people in exchange coverage. So good point. David.
Liz, I'm going to offer a contrarian opinion, see how folks feel about this. So I think the commission has directed us to price out a design that has no cost sharing for the reasons that public commenters have articulated and for the reasons that are shown on the screen here. So we're going to have that, and that will be the most expensive premium for whomever is paying the premium. In our modeling, we will also have the other end of the extreme with a silver cost sharing design. That's a 70% actuarial value, whereas zero cost sharing is 100% actuarial value. So we will be able to articulate, we should be able to articulate to the commission how the cost to whomever was paying the premium gets shifted from those folks to the patient when you impose a 70% actuarial value. And I think it just goes back to Kai's point of, in an ideal world, none of us as patients would have to bear any cost sharing, but it becomes a budgetary balancing act to figure out where to fall in that spectrum.
Right. That's a great point. And like our friends from Vermont said, that's ultimately what I think taped things is that the sticker shock scared everybody. Couldn't even talk about the other models. So
yeah, so I guess for me the take home points, I don't know that we need to come up with principles because we've already been directed to put on the table a scenario that
with no cost sharing.
Zero cost sharing. Yeah.
So I guess then with the principles here would be focused then on whatever else we're going to ask for Milliman to model. Okay, Roger and then Pam.
I leave aside, let me say this. I asked a question about principles. So let me push back a little bit on David's. So let's assume something we've talked about is saying cost sharing reduces spending, etc. And we said, well, we're going to do the cost sharing design. We've talked about this. We want to incentivize appropriately. And e.g., no cost sharing on preventive care as an example here. I think laying out some of those principles will help when we go through the AVU modeling. So I would advocate that we try to hold to some principles. And, let me just try another one, if I might briefly, because it's kind of controversial. Let's say well, we're going to have cost sharing. We're going to model that certainly. And there's an argument to be said for having co-payments versus co-insurance versus deductible. I'll use that as an example. And a lot of folks say, well, let's do co-payments because you know what your exposure is going to be, right? Deductibles, you kind of co-insurance, you don't know it until it's there. So we may want to say something about
the types. Yeah.
To reduce, uncertainty or whatever is the cost sharing structure should be based only on co-payments. I'm just
throwing it out there.
Example.
Yes, got it.
So I think the principles, I guess I'll push back in there, might be helpful.
Because we are going to get asked about it probably when we see the giant sticker shock. So we need to have something to guide what we're doing. Pam?
Yeah, I think I may be repeating, but just to kind of to David's contrarian proposal. I think that actually I sort of initiated the idea of talking about principles because in my conversations with the Universal Healthcare Commission members, they were very much the strong preferences towards absolutely no cost sharing.
Nothing.
And my concern was that that may not be realistic in the end. And so I asked Vicky, who is the chair, I said, would you like us to give you some options to look at in terms of cost sharing? And I think she was enthusiastic about that. Even if she's not enthusiastic about cost sharing, she was enthusiastic about having options. And what I felt is in sending those forward, instead of just like it costs this much here and costs this much there, to also, since we're more inclined to think about cost sharing, to help them think about how they would look at those questions and have that debate. And even if they don't even like our principles, if they throw them all away and want to start over, that still stimulates them to think about how and why they would approach cost sharing. So I think it's much meant to be useful to, to them.
Thanks, Pam. David?
I think I appreciate all that, Pam. I think the commission, the big question they're going to be faced with is 100% actuarial value, 90%, 80%, 70%. Yeah. Secondary to that would be, okay, if you settle on 80%, you can choose to cover preventive services at zero. You can choose coinsurance versus copay. Same thing at 70%. So to me, it's a second layer decision after you get through the big financing questions of what actuarial value are we going to finance or not.
Other folks?
Yeah. It's Roger. Sorry again. Back to David's. Sometimes my thing will work. This is an interesting one for Peter. And I'm trying to tie it into David's comment. Let's assume, for the sake of discussion, we have, no cost sharing, so actual value at 100%, and we have these step downs. And Peter, how would you propose that you and your analysis go through developing, let's say, a model that achieved a 95% actuarial value? You're going to have to do some adjustments on, on kind of some services and utilization impact. Are you able to do that in a way that doesn't require us today to go through a service by service discussion on should this service have it or not? Am I making sense? My question.
Yeah, I think I would say that's why we selected some existing, sort of structures that are viewed as sensible, or at least are on the market now, I suppose I should say. I would say in the long run and sort of outside the scope of our analysis or perhaps even the discussion today, no, that if you want to project, the benefit expense for a specific set of benefits and cost sharing values and populations, it really is an analysis that requires essentially all of the nitty-gritty detail. So I don't think there's a shortcut around that in the long run. In the short term, I think, provided we're on the same page, our analysis is intended to give you sort of a very broad strokes menu of, extremes between Medicaid-like cost sharing and silver benefit like cost sharing on the individual market. Does that make sense? Did that answer your question?
Yes. If I make one more declarative statement, I promise to shut up. I'm personally troubled. I'll tell you why. When we go through this cost sharing analysis, this AV range, I get, no cost sharing, so that's Medicaid. When we look at the silver plan with an actuarial value of 70%, and that is the highest plan participation, there are some confounding factors in there. One is that there's cost sharing subsidies, significant cost sharing subsidies that are only available to folks who are in the silver plan. And, I would raise a question if those cost sharing subsidies weren't there. 30% borne by the beneficiary is a pretty steep curve. And to me, I would be very troubled. I mean, we think we need to model it, but I'd say I would be extremely troubled to say, well, these are our array of recommendations without having a complementary set of subsidies into that. And that's what the silver plan does. I mean, I understand people want to use it for a benchmark to comparison, and I agree with all that, but
So I think what I hear you saying, Roger, is so I just want to try to get some clarity. We talked about first, I just want to get clear. Does this group feel comfortable with having some declarative statements like the 5 that Roger shared, that we acknowledge the impact of cost sharing and that it can be detrimental? The 5 that were in the rant thing is just a starting place. Just want to ask that question quickly. And then the next question I have, Pam and team, is do we then want to shift to the what I feel like we're circling around, which is there may in fact have to be cost sharing, and here are the things that we would like to put forward, that 70% is not a high enough AV, that we want it only on certain services. People in Medicaid, people should not have to pay any more than what they're currently paying who are in public programs, because it's going to be really hard to get through any type of approval on that. So just want to kind of see if something like this is what folks are, if we're comfortable with that. What do you all think? Hi.
Yeah, that all sounds good to me. And so specifically, point 3 there that you're showing from Roger's points, I just wanted to clarify the latter half of that phrase, the costs of care were not affected. Roger, do you mean total cost of care, downstream cost of care?
Yeah, that's a great question. I meant by yes, the unit price, if you will, for the service.
Oh, the price. Okay, got it. Thank you. Okay, thank you. Yeah, so yeah, I'm fine with those 5 points. Roger's earlier comment to Peter, I think, sort of stirred a thought in my mind. I just wanted sort of clarification on the modeling. Peter, like the 3 scenarios that you're modeling, how are you accounting for the scope of services that are covered? Whether certain types of surgery or what elective surgeries or so on are covered under the different benefit designs, not explicitly cost sharing, but like definitely related. And so the broader comment, I guess, is to the group is like, effectively, you not covering something, right, is effectively 100% cost sharing, right? And so one response, if if we're sort of like our remit is to have 0% cost sharing, you could achieve that and perhaps achieve budget neutrality if you were to keep the scope of services extremely small, right? Obviously, like that's an issue, but like that's the sort of another sort of dimension of the interplay. So yeah, question to Peter about like how are you accounting for scope of services covered?
So the benefit packages that we outlined, so the PEB, SEB, the Silver Plan essential health benefits, and the Medicaid benefits, those define what services would be covered or not covered in each scenario. So there is going to be some changes there for basic medical benefits. I don't think the changes are that significant, although I don't have the benefit sheets right in front of me right now, so I could be overlooking something off the top of my head.
Christine?
Yeah, so I just wanted to go back to the question about whether we'd want to endorse this statement. And I feel like there would probably be a few tweaks, like the point that Kai just made. I think we'd want to reword that. And then there are a couple of other things that I would maybe quibble with here. And also with the 70%, I'm not sure I'd want to necessarily go as far as saying it's too low. I think we might be concerned about it, but anyhow, these are minor quibbles, but I just wanted to, maybe the bigger point is I'm not quite comfortable just endorsing this as written.
So let's talk about this. Yeah.
Sorry, did you want me to say
Yeah,
more about
I think it'd be great. Yeah, Mary, maybe why don't you take these 5 and copy and paste them into the Word document, and then we can work on them as a group or at least just point out where we have concerns that the staff can come up with something and send it out if we can't. We don't have to get into the whole wordsmithing thing together, but oh, that's funny that I did that. Okay. Christine,
It's
why
because
don't
it
you
came
start
out of a
talking?
PDF. I'll
I
fix it.
know. It's okay. Christine, why don't you start talking and we'll try to
Yeah,
capture
so
it.
these are like tiny things. They're just so one is I don't really understand the point that that the reduced spending resulted entirely from the lower use of care. I would think some of it would have to be from the additional, the lower per unit cost paid by the payer. So maybe primarily or something like that. Although maybe I have to go back and reread the HIE, but I think the price as opposed to the unit cost or the cost would be the appropriate thing in 3. And then in number 5, I had thought that the findings were really all about the poorest, and I'm not sure about the sickest, but I might be wrong about that. But I would just want to double check before we assert that. And then I also wondered if we would want to bring in the more recent findings from the OAG, as Kai had suggested.
Okay. Kai, can you make your comments on
OAG?
with these in front of you? Yeah.
Yeah. So I can copy and paste in chat from the New England Journal abstract, but he said in essence there we found the researchers found that among the Medicaid population, reductions in cost sharing did not impact physical health in the first, I believe, 2 years of the experiment. But that's not to say that it didn't have other important impacts on like financial strain and sort of like access and things like that. And so maybe the other comment is that like we're talking about coverage and insurance, and uh, I think perhaps it's important to point out that like the insurance is a financial instrument to protect against catastrophic events. And so even if it has no impact on patient health, like it has a benefit, especially to those who are of low income.
Okay.
Like because like healthcare is as Rand and others have found, like it's like largely price inelastic. It's people are largely speaking on average going to get the services with a little bit of reduction of utilization, and if that's the case, like the sickest people will be most impacted by these unexpected high cost events that would be covered, that would be sort of addressed by insurance. Even if it has no impact on their health, it helps them through sort of financial mechanisms, right? I'll draft something and put it in the chat.
That'd be awesome. Thank you.
Guys, excuse me, interrupt. Do you have that Oregon study? Because that was when they did up to 100% randomly assigned folks, right? And they looked at.
Yeah, right. Yeah, I'll put it in chat.
Yeah, I would like to have seen that. Thank you.
Is there something I just want to go back to one of the questions that I feel like our presenters in July circled around is, do we want to make a statement about how we view cost sharing? Do we want to say it's primarily we're not looking at it as a funding mechanism, it's primarily for something else? I feel like that was one of the trade-offs that they were trying to help us kind of wrap our brains around. Pam.
I don't know, I'm trying to be helpful, so, but I
No,
think
this is new.
what you're hearing here is, I think, you know, you're hearing a very more of a clinical academic approach to cost sharing, which is this is what the studies show. And the more you dig into those studies, sometimes you can get very confused because they don't show what you expect they're going to show. And there's some issues just almost in terms of, you know, diversity, equity, and inclusion of just protecting people from adverse, you know, economic events, even if they might still be able to somehow seek out the care and get the care they need. So, you know, you can get into swirling on some of these topics, but I think that in listening to the conversation, I'm hearing, I don't think we've heard from Bob yet, but from others, people kind of broad support for doing this, with some reservations from David because of wanting to start with the math and then to move to the, you know, the particulars, which is a good way to go. But I think that for the committee we're wanting to communicate with, I think the language will be helpful to go with first. And then I think that people will want, given the level of conversation here, I think people will want to have a chance to edit whatever.
Yes,
Yeah.
100%. And
Yeah.
I think you're right. That is one of the differences between this committee and the commission is that I think for them it's going to resonate more being able to hear like this is what we endorse as a commission. Instead, I think the math piece is probably, you know, would be secondary to them. Oh, and Christine's putting a bunch of things in chat. So
Sorry, I just put 2 things in chat.
no, that's great. I think that's great.
And I will add those later. I can't see them right now, but I will be able to add those comments later to these notes before we circulate
And I
them.
can't cut and paste from the chat from the state. I don't know why, but that's I've tried too many times to try it again.
These are
But we'll get it
primarily
afterwards.
their references.
Yes, we'll get it. Thank you to everyone who's sharing the information.
Will we be able to save these references? I'm sorry, I'm being stupid because I'm not really zoomed up.
Yes, they'll be captured in HCA's record, and then we can go back and grab them. Eddie, I saw your hand up again.
Yeah, I know when the studies that you're referring to, I haven't looked at them, but I always have this traditional model of cost sharing, and it's with the old traditional plans. And so I just want to make sure that we're comparing apples and apples. So when we're talking about cost sharing, we're not talking about, you know, a 80-20% type thing. And then there's an out-of-pocket maximum because we're looking at a PMPM that covers all of that. And this is purely just a, you know, a fee that you're going to assess when they come into the office and pay as the cost sharing piece. Is that what it is? Or is it something else where they're going to look at these different procedures they're going to go into and you're going to assess some cost impact based on that?
Yeah, I think that's actually a good question for this group is when we talk about cost sharing, do we want to delineate between like co-insurance? I think it was you, Roger, that said like it's easy to when you go into a doctor's office or when you're paying for your medicine, you know that this is my cost sharing. It's pretty easy, but then there's things like co-insurance that are not like point of service. So does this group want to say something about those different kinds of cost sharing? Should there be certain types that are okay and what tool, getting more specific in types of the tools? Do we want to say something about that?
Liz, this is Roger. I would recommend that we that's maybe with the guiding principles, try to get those in place first, because we're not going to have the ability today to sit and design a cost sharing schedule.
No. Yeah. We're going to take this and come up with something. Okay.
So I mean, I think that I think as a first step to kind of sizing things and providing guidance back to the commission is to say, again, I go back, here are these 3 benefit designs, and we do simple AVU analysis here's what that translates to PMPM that's borne by the payer and by the individual, the Milliman modeling. I think if we can get that far along in our analysis with some kind of clear guiding principles that we maybe continue to enhance, that's not a bad step, because I just think otherwise we're going to get ourselves in a trap of having to go through and actually do a very detailed cost sharing design.
Right.
We're to do that. So we all agree that we should have a 90%, actuarial value. Okay, so what do you do with that 10%? I'm just going back on that again as to say, well, that's hopefully these guiding principles will give us some sense of what to do with it.
Yes.
But not getting into a procedure by procedure code level.
Right.
Okay. Have guiding principles.
Okay, that sounds good.
Do you have what you need, Liz?
I think so. I hear what you're saying, Roger, on I've heard the comments about, types of services and things like that. But so you're saying that we don't want to kind of delineate between the different types of cost sharing.
Well, no, I think,
or do we want something? Do you want us to include something as a draft up something for you all to react to on that piece?
Well, I guess I would recommend, I'll shut up.
Oh, Kai, go ahead.
Sorry, Roger, if you want to finish. Okay. Oh, I wanted to react to Liz's question about and Eddie's earlier point about transparency and out-of-pocket costs. I think there could be a principle there as well, where like earlier we said we sort of set this assertion around cost sharing should be as low as possible, subject to budget constraints. Maybe there's one around cost sharing is incredibly complicated, right? Like we don't know. Us as patients and as caregivers, we don't know, right, how much something costs when we go, when we seek care, and maybe there could be a principle around cost sharing structures should be as simple as possible, subject to, I don't know what X is. We'll have to think about that, because there is a clear trade-off. At least there is a trade-off in my mind, right? Like for example, like high deductible health plans, there have proliferated in the last more than a decade. And the reason why is because they do impact utilization and save plans money and so on, but also introduce a large degree of complexity and uncertainty for patients. And so something around like cost sharing should be as transparent and easily understood as possible for patients, subject to something.
Great, I appreciate that.
A question: Does that lead you to? Because when I think about you about simple, excuse me, it raises from the beneficiary's perspective of, do we want to make any statements about the types of cost sharing? I'll make an example here, saying for simplicity, we would tend to encourage co-payments because the beneficiary has a clear impact of their cost obligation versus co-insurance, right?
Yeah, could be. There's different gradations of that, I guess, that we could spend many hours discussing, but like that, I think it also goes back to the earlier conversation about how many tiers of copay do you want and that sort of thing, or do you want just two and so on. There's I think different nuances that we could discuss.
At what point is the juice not worth the squeeze for like the providers to collect it? I remember, Roger, that's one of the first things I met you on was premiums for kids and Medicaid, and it was like it wasn't worth it. So anyway, for the provider community especially. So okay, I'm gonna stop.
Yeah.
I feel like we've got enough for us to go and do some work and bring back to all of you to help us get it where it needs to be. I'm going to hand it over to Mary.
Well, actually, I was just going to say the same thing you just said, Liz, that we will take these notes. We have the information in the chat. We will be, making this a much neater document that we can share so that people can react to. And Liz, I don't know if you wanted to go to your very last slide.
I think, just to kind of spell out what happens next, I think that would be good.
Yeah, so I will stop sharing. And thank you, everyone.
Oh, wait, am I sharing that slide or are you? Or somebody else
I think
is
Audrey
sharing
has it.
Sorry, Audrey. You've gotten us out of our normal pattern of
Exactly.
things.
I stole the screen and confused everything.
Okay, so keep going. It's just to state the obvious. We're going to take all this. It's been really thoughtful and draft up some principles to serve as guidance. We'll bring it back to all of you. You'll be getting it via email for you all to tweak, improve, refine, and then we'll share it with the commission at their next meeting. And I think, kind of, again, the balance that we're going to try to strike is trying to put this in some plain language terms so that they understand what we're talking about and feel comfortable with, okay, the people that are the experts on this gave us this guidance about what we should be thinking about. So we'll share with the commission at our next meeting of FTAC. We'll be diving into the provider reimbursement and cost containment variable conversation to think about what we want to give the commission, if we want to get what kind of principles we'd like to give them around those two factors so that they can think about it when we get our step one analysis that Milliman is already working on, so that they feel prepared when it comes back and says, oh my gosh, it's this expensive to do it. We feel like they have something that they can point to say, okay, we know there's going to be trade-offs, and here's how we've decided we want to approach this piece of the puzzle. So those are the next steps, and I think we're wrapping up.
All right.
Yeah.
So I would, this is a follow-up. I would hopefully we're all comfortable at this juncture of, we're working hard at this, of providing a set of options. We're talking benefits, cost sharing, and all this sort of stuff. We should be very comfortable about that, maybe with our own personal with the recommendations, but back to the commission. And I don't know if others agree with this. My guess is at some point in time, the commission is going to be putting something together to go forward back to the legislature.
Mm-hmm.
And while there may be a recommendation from the commission, and Pam can speak this well too, I will assure you that they will want to see options, lots of options. And the work that we're doing now is providing the foundation for those lots of options. Because I can see this going back to the legislature with, here's look at all the options, here's the one we chose. They're not going to be, satisfied with it no matter what, and they're going to be asking for a series of options. And the work we're doing now, I think, is setting the stage for that. So I think we should feel, comfortable with what we're doing the case. Pam, do you have any comments further on that one?
We're making progress. I'm going to hand it to Mary.
Fair enough.
Yeah, I just wanted to jump in one more time before, because I know we're about to wrap up. Our earlier conversation about seeking liaisons from the committee to work with Milliman on this analysis. Again, if you're interested in learning more, have questions about it, please reach out to the HCA FTAC mailbox that I should know off the top of my head, but I don't. But it's the mailbox that we use for communicating with you. So you should have messages from there. So please feel free to reach out and let us know if you're interested.
Yeah, we could just send a message from that mailbox and then people can reply if they're interested.
Sure, I will do that.
It'll be a sure thing. Yeah.
All right. Have a good September, everybody.
Is that, are we wrapping up? Okay. Thanks. Thanks, everyone.
Thank you.
Thanks, everyone.
Thank you.
Okay,
See you
great
next
meeting,
time.
great discussions, and obviously a lot more to follow.
Thank you.